started, not you.
Dr. Chan, would you like to say something?
You want to do some comments?
I thank you for the guest speaker, John and Debbie. This actually is my last clinical run here as presenter.
No, no.
Yes. Also maybe the last one. I may come in next Friday, but I don't know. I'll go California. There is a picture that NIH picture, and if you haven't signed yet, I welcome you sign. So they will ship it to California, my home. I'll remember you. Today we're going to talk about XP and the world expert, Dr. Kramer, and the world expert for ophthalmic condition, Brian here, and they will give us talk, and then Moniz will talk about the EM, and Ian will talk about the pathology of the patient. Thank you.
Thank you. It's a pleasure to be here. I have, you can actually make this into a laser, Brian, when you come up. I'll show you how to do that. Otherwise, the pointer doesn't work.
Yeah.
Yeah. So it's really a pleasure to be here. We'll be talking about xeroderma pigmentosum, and we usually think of it as a dermatologic disorder, but really is equally an eye disorder. The problems that these patients have, and we're really so grateful for the interest and expertise of the people in the Eye Institute for so many years, because our patients come in, and some of them have been blind, virtually blind because of the sun exposure. And you guys have been so helpful. And then we do the pap smear of the eye with the shot of our corneal swab, and that's been very helpful as well. So it's really a pleasure to be here and just let you know what we've been doing and what we've learned from it. So I'll be focusing on the eye. And if we figure out how to do this, I'll give you a little background about xeroderma pigmentosum, or XP. There's some of the clinical features. These are patients we've seen here. They're very sensitive to the sun, and you can see the face of the child who was exposed to the sun. They have the changes that are, we don't want to lose this, changes that are those seen in a farmer or a sailor with many years of sun exposure. She's only about 10 years old when this picture was taken. You can see the changes occur in the sun-exposed portions of the body. The buttocks that is doubly covered doesn't show these changes. And this is a 9-year-old, actually, with many of these pigmentary changes, including and a scar from removal of the skin cancer. And then here's another skin cancer. And then the eye is also involved. This is actually XP1VE, and the first patient seen at NIH. And she had significant eye problems. Brian will be talking more about those later. So this has been also called a disease of premature aging, or premature photoaging of the epidermis. So people in the Aging Institute are very interested in that. So XP is a genetic disorder. It's autosomal recessive and equally distributed among males and females. It occurs throughout the world. In the United States, the frequency is about 1 in a million. It's much more common in other countries, such as Japan, where it's 1 in 20,000. The oldest patient we've seen is in his 70s. However, the symptoms often begin very early in life, a year and a half, for the sun sensitivity or freckling. Interestingly, only about half of the patients have a really acute, severe burning on minimal sun exposure. And they often are kind of blistered and are taken to the emergency room, and it takes a while for the diagnosis to be made. Sometimes the parents are accused of child abuse. It's really very unfortunate. But the other half get this freckling and then start to get skin cancer, and the median age of the skin cancer is only 9 years old. So in the past, death occurred 30 years earlier than in the U.S. general population. However, with some protection and early diagnosis, they occur 1-to-1. So this is a study we did a number of years ago about the frequency of skin cancer in XP patients. The basal and squamous cell cancer is the most common, and that was occurring at several thousand-fold elevated rate in people under 20. Melanomas are also increased, and eye tumors are very commonly found in these patients. And so here is a 1,000-fold increase. Also tumors of the tip of the tongue. I want to point out here that most of these tumors were all in sun-exposed sites, but patients also have an increased frequency of internal tumors, particularly those of the brain and the central nervous system. And today we'll be talking about another internal tumor that occurred in the back of the eye. And so this is another way of looking at this data. Portia Bradford, who was a fellow in the epidemiology branch, worked with us. We plotted 100-some-odd patients that we saw over 40 years, and the median age of onset of skin cancer was 9, and that compares to the general population of 67 years. So there was a 58-year reduction in the age of onset of skin cancer. That tells us how important DNA repair is in protection against these skin cancers. And if you do the calculations, this is a 10,000-fold increase in skin cancer. We did a similar analysis for melanomas in these patients, melanomas of the skin, that is, and the median age was 22. See, that's older than the 9 years of the non-melanoma skin cancer. And in the general population, melanoma occurs somewhat younger than the basal and squamous cell, but still it's earlier. In the XP patients, it's 33 years younger. But just by looking at these numbers, you can see that the melanoma induction is very different from that of the non-melanoma skin cancer. And you can learn about just the basic mechanisms of carcinogenesis by studying these rare diseases. As I mentioned, the eye is involved as well. Here's a 7-year-old with a squamous cell of this conjunctiva. And Brian will be going into more detail, but ultraviolet radiation is absorbed by the anterior portion of the eyes, the cornea and the lens. Visible light is visible because it makes it to the back of the eye. So most of the changes we see in the XP patients are in the anterior portions of the eye, and we can then see that it's due to the ultraviolet radiation exposure. The tumor today that we'll be talking about is in the back of the eye, in the uvea, and that is thus an internal tumor, and that differs from these other tumors that we've been talking about. So what was the problem with the XP patients? Ultraviolet radiation causes damage to the DNA, causes photoproducts. The main one is the cyclobutane pyrimidine dimer, shown here. Also the 6,4 dipyrimidine photoproduct. This is formed in a ratio of 3:1. These are very stable. There's a nucleotide excision repair pathway that normal cells have to remove the damage. It involves recognition of the damage, unwinding the DNA, and then incision and excising the damage in a piece of about 30 nucleotides. It involves multiple proteins, depending where the damage is, and whether it's in actively transcribed genes or elsewhere in the genome. That's called transcription-coupled repair or global genome repair. And these genes are given names such as XPA, B, C, and we see in this our patient today, there's a mutation in the XPC gene, and this is a protein that's involved in the initial recognition of the DNA damage. So then we move to the patient. We call these patients XP and then a number and BE for Bethesda. This started when I began in the early 70s with Dr. Jay Robbins in the dermatology branch. And cells from these patients have become available in the cell banks and are studied widely throughout the world. So even with this rare disease, many scientists are able to study it. So the patient was born in 1994. He was normal gestation, but he had low birth weight. He had jaundice and fetal alcohol syndrome. Unfortunately, his mother was involved with substance abuse. year and a half, he developed his first skin cancer, which was a basal cell carcinoma of the nose. They didn't diagnose xeroderma until he was 3, but he wasn't that well protected from the sun. So he had multiple cancers on his face, nose, lower eyelid, and many reconstructions, surgeries. He also had attention deficit disorder, probably related to the fetal alcohol syndrome. We first saw him when he was 10, and at that point we examined him. He was the 10th percentile for height, 25th for weight. His head circumference was less than the 3rd percentile. This is unusual for XPC patients because they generally don't have neurological involvement, but he does. And it's more common in patients who have defects in the XPA or the XPD gene to have a microcephaly. And those patients have a progressive neurologic degeneration. And we think what he had is more related to the fetal alcohol syndrome. He had the typical XP pigmentary changes on sun-exposed skin. Neurology showed increased reflexes. In fact, the XP patients who have neurologic problems generally have decreased reflexes and clumsiness. We have the neuropsych testing here. It showed a 3 to 4 year developmental delay compared to his 10-year age. Audiology, he had a mild conductive hearing loss and an infection in his ears. The XP patients who have neurologic problem have sensory neural hearing loss. So for all these reasons, we think that his neurological problems don't relate to the XP. His MRI was normal, and we did the DNA repair testing. Dr. Khan, who was here, determined that he had a mutation in the XPC gene, and it was a splice site a mutation. It was either homozygous or hemizygous. So here's what the patient looked like when we saw him. He was 10. You can see the pigmentary lesions on his face. He was actually short in stature. This is what he used when he went outside for sun protection after he was diagnosed and moved to the care of his maternal grandmother, who took much better care of him than his parent, his mother. So these are lightweight garb that is made of UV blocking material. And you see he's wearing gloves, long pants, long sleeves. When he was 12, he was diagnosed as having essential hypertension, and then the second visit, we saw him, he was 15, and he had hypertension, low red count, elevated albumin-aminotransferase, and here he developed mild sensory neural hearing loss. We were able to do IQ testing. It's very low, 58, and he had a slow speed of mental processing. In 2013, he was tired. 2014, they did a bone marrow biopsy and showed myelodysplastic syndrome with multiple chromosomal abnormalities in the bone marrow, including monosomy of a number of chromosomes, including chromosome 3. We'll hear more about this later. He also had pancytopenia, had to receive multiple transfusions, had a liver biopsy in 2014, showed hepatocellular adenoma and extramedullary hematopoiesis. And then they attempted a bone marrow transplant in November of 2014, and then he died of complications for that. He was 8 years old. That was this past December. Debbie was able to arrange for an autopsy. He was living in the southern United States, but they transported the body here. The family generously permitted us to do a full autopsy. They found the cause of death was lung damage, diffuse alveolar damage, complications of bone marrow transplant for myelodysplastic syndrome. He had hepatosplenomegaly, hepatic adenomatosis. This microcephaly was there. Again, we think that might be due to the fetal alcohol syndrome. And then very unexpectedly, discovered that he had an ocular melanoma. He had no other melanomas on his skin at the time. In fact, he had no tumors of his skin. But we said, let's contact Dr. Chen and say, we have another XP patient. Let's see if you could help us out. Ian came down. We That's all I have. Take it to Brian.
Dr. Berger, was there any evidence of consanguinity in this family? He was either homozygous or hemizygous, you said, for a mutation. And this seems younger than for systemic cancers than some of the other patients, at least that I've seen. So is it possible that he actually has more than one thing? We know he has more than one thing because he has fetal alcohol syndrome. Is it possible that he has a second genetic thing?
Debbie is not a yes.
Okay.
But we didn't get into that for various social reasons.
Okay.
It was a very dysfunctional family.
Yeah,
Okay.
it was a very dysfunctional family.
Okay.
Let's just leave it.
All right, fair enough. So it's a real pleasure to present at this Dr. Chan's last round. So as Dr. Kramer mentioned, this is a 10-year-old. I saw this boy when he was 10 years old. He had been diagnosed at age 3 and was not well protected from the sun. Prior to that, he had required multiple skin surgeries, including on his cheek, which was causing a right lower lid ectropion, which required a subsequent skin graft. He required, he complained rather of bilateral, oh, sorry, goodness gracious me, what did I do? Oh my goodness, all right, thank you all for coming. Oh my goodness, all right.
I can show you how to make a point.
Yeah, that would be fantastic.
It's not that big. It's go to this thing.
Yeah.
Let's get here. Put your cursor on that. You can move it to the right side.
Yeah.
Oh, no.
Get on this little thing. Check on laser.
Fantastic. Fantastic. Great. Thank you. So he was complaining of bilateral chronic eye redness, but no tearing, and he was already using artificial tears in the morning and a lubricating gel at night. He had a history of strabismus as an infant, possibly exotropia, and had been patched for some time. He also had, he's opening his eyes a little bit more here, but he had bilateral ptosis with a margin to reflex distance of about 1 millimeter at baseline. He was 20/40 in his right eye and 20/30 in his left eye. He had essentially no stereopsis, consistent with his strabismus as a young lad. His pupils were normal, as was his gross motility. He had an intermittent exotropia that was comitant and easily dissociated, greater at near than at distance. And he had, as we'll discuss with other XP patients, low baseline tearing. This is particularly important in this patient population because Schirmer's testing is not something that, as pediatric ophthalmologists, we typically do, think about. On his right eye, he had telangiectatic vessels, ectropion, as we've discussed, with subsequent keratinization. He had a skin graft placed there. There were missing lashes pretty much the entire length of the lower lid, and his lower punctum was scarred. He had +2 injection, especially on the bulbar conjunctiva, had the start of a pterygium for about 4 clock hours, extending roughly 2 millimeters onto the cornea, a mild punctate keratopathy consistent with his dry eye. And there was an area, it's hard to photograph, but Denise kindly at the time outlined it for us with the yellow line here, showing there was an area of epithelial overgrowth without any real vascularization, and that was suspicious to me. It was subsequently biopsied and was found to be non-cancerous. His lens, retina, and nerve were all normal. The left eye, perhaps a little bit less involved, also no tumors. There was lash loss across the lower lid, and his lower punctum was scarred and out of the lake. He had some chronic conjunctival injection, also a milder pterygium for about 3.5 clock hours, extending about 1 or 2 millimeters onto the cornea with mild punctate keratopathy, again, normal lens, retina, and nerve, which which is a theme. Dr. Kramer mentioned what he affectionately calls the pap smear of the eye. This is conjunctival cytology. And here I have to say, this is one of the kind of special things about working at the NEI, and specifically about having Dr. Chan around. This was developed by Janine Smith, Janine Clayton now. At the time, for looking at chronic effects of dry eye, I kind of abrogated it for use within XP, and it has been very enlightening, at least in some cases. So this is very simple. It's not under topical anesthesia. It's a cytospin with gimsostain. This is the cytology not from our patient, but from another patient that was severely affected. You'll recall that the conjunctiva goes through layers of maturation, and that normally you would not see mitotic figures on the surface of the conjunctiva, but in this particular case we saw one. Dr. Chan had never seen one before up to that point in time. We also see these keratin-containing cells from time to time, as well as signs of both acute and chronic inflammation. This particular chap, I think Ian will show you, had a few polymorphonuclear and lymphocytes, and there were some small irregular epithelial cells with dense chromatin. So in summary, this was a 10-year-old boy with XPC in this case, with a history of suboptimal protection from UV light in the first few years of life, bilateral lower lid abnormalities with no evidence of frank cancer, bilateral conjunctival injection, dry eye, punctate keratopathy, and pterygia, and there was an area of non-cancerous overgrowth onto the corneal epithelium of the right cornea. So as Dr. Kramer mentioned, the damage that is done by UV light is largely an anterior segment thing. So it is not uncommon, as in this patient, to see damage to the ocular adnexa, to the conjunctiva, to the cornea, but nothing really beyond that, by and large. Once you get to the lens and the retina, we don't see much in the way of pathology. Specifically, we don't see like age-related macular degeneration, which as a premature aging syndrome you might think might go with that, but it doesn't. The exception to this is that there are some ultra-rare overlap syndromes between XP and some of the other DNA repair disorders, such as trichothione dystrophy, where you can get involvement in the lens, or Cockayne syndrome, where you can get a frank retinal degeneration with that. And we've seen those here. This patient did not have that.
Brian, can I just, sorry, I don't know if you're used to jumping in.
Sure.
So this is really a very important point, and one of the issues that comes up occasionally in dermatology, and is not thought of terribly seriously, is the effect of visible light on a variety of biological processes, skin cancer being one of them. And the question in these individuals that are very sensitive is that it's not clear which wavelengths may penetrate more deeply, and if all of the UVA is blocked. So do you have any idea how this information was developed, and how accurate it might be? I stumbled across an article that I don't have at hand, which is relatively new and I will send to you, that actually looks at the different wavelengths and talks about some of them penetrating to the back of the eye. And I think that becomes an issue then for some individuals who may not repair damage in different ways, in different broken ways.
Yeah. So the literature that I'm aware of is very, it was very old. When we were writing the article, and I actually forget the precise methodologies because it was decades old at the time that we were writing the review article. This particular picture was just pulled off the web, so it was a Google search. So it is quite conceivable that with newer methods, for instance, that perhaps there is a portion of UVA that does get further back to the eye than what was expected.
Yeah, I would agree with that. A lot of the work was done in the context of visual pigments, which cut off below 400. And when I read old literature, there are not specifically on this, but in general, there are sweeping statements that were appropriate at the time, but in retrospect, You wish they were a little more precise, but they didn't have a reason to be. And in this condition, you mentioned the 10,000-fold increase in sensitivity, essentially. The precision of penetration of wavelengths through the lens, I think, would be extremely ambiguous at that level.
Yeah, if I recall when we were looking it up at the time, the person doing the work was the guy whose picture is right behind you there.
Dr.
Kogan.
Yeah. So we reviewed the NIH experience a couple of years ago. We've had a great relationship with Dr. Kramer and his group through the years. So we reviewed the records of 87 patients, and as he mentioned, this may not seem like a lot, but this is literally a 1 in a million disease in the U.S. The ages ranged from a little over 1 year of age to 63, and we looked at the full gamut that had been seen since the 1960s. About 50 had a single visit and 37 had more than one, with a total of 331 visits analyzed. 3 had a combined syndrome of XP and Cockayne syndrome, and 1 in this analysis had combined XP and trichothiid dystrophy. All had complete age-appropriate eye exams. We used kind of standard clinical metrics, visual acuity, eyelid evaluation, ocular surface pathology, which is not standard, but is a good thing to do here, tear film and tear production, and cytologic analysis of the conjunctival surface. So, as Dr. Kramer alluded to, XP is a dermatologic disease, but it's also really an ocular disease because over 90% of patients had at least one significant abnormality on their examination. And as I mentioned, because at least canonically the UV light is largely absorbed at the level of the anterior segment, the pathologies we observed were largely the front of the eye. One thing to stress, and Dr. Kramer also alluded to this, is that XP affects people of all ages and all ethnicities. So we have a young African-American girl showing early freckling. This is a young woman in her teens at the time, Native American. She was not particularly well sun protected. She's actually sunburned at the time of this photo with multiple lentigines across her face. This woman was born in the Dominican Republic and had essentially no protection growing up, and is Hispanic by background. And this is a Northern European Caucasian who had very severe disease, had bilateral, I want to say invasive squamous or basal cell carcinomas requiring bilateral exonerations, and she eventually died of a systemic cancer. So this is a 5-year-old girl, lentigines. She had blepharitis and conjunctival injection, not particularly seen on this. This is a 13-year-old. She had multiple non-melanoma skin cancers, removed since the age of 5. She was sunburned, as I mentioned, and had bilateral conjunctivitis, which you can kind of pick up here. This 39-year-old woman grew up in the Dominican Republic without sun protection and multiple non-melanoma skin cancers, removed since the age of 7. She had very severe conjunctivitis, bilateral ectropion and entropion. Her left cornea had severe pannus, was completely opacified. She was essentially light perception, and her right eye was enucleated at the age of 20 due to sun-induced damage. Lastly, this 46-year-old woman had multiple melanoma, non-melanoma skin cancers. It was an invasive basal cell carcinoma. She underwent complete orbital exonerations at age 32 and 36, and then died, unfortunately, at age 49 of uterine cancer. Structural abnormalities, the eyelid are common, so about a quarter had ectropion, about 2% had entropion, 10% had lagophthalmus. Dr. Kramer alluded to there are 2 broad classes, those that have early burning and those that don't. And the non-burning patients experienced a higher rate of ectropion than burning patients, and we felt that was probably due to avoidance. When you get a really bad, these are really bad sunburns that the kids get, that probably leads to a change of behavior pretty early, whereas folks that don't have that phenotype may not have that behavior, and that may lead to more chronic damage. lid keratinization and missing eyelashes were also common. Eyelid pigmentation, perhaps not surprisingly, was very common in pigmented races, and blepharitis were also frequently observed. Lid neoplasia was observed within our study, but this probably represents an underrepresentation of the real prevalence of disease, because largely these would probably have been handled by the referring home ophthalmologists. Conjunctivitis, which our patient had, was probably one of the most common findings that we saw across the board. About half of our patients, especially in pigmented races, we saw ocular melanosis, and sometimes it became a little bit difficult. We were worried, for instance, about this particularly melanotic lesion of the conjunctiva with what appeared to be leash vessels kind of feeding in and feeding out. Interestingly, the findings are not necessarily limited to the sun-exposed areas, which is what you might think based upon the dermatology phenotype, and I'll talk a little bit about why that might be. Tear film abnormalities were also pretty common in these patients. Recall that at least canonically we think of basal tear production as something related to the accessory lacrimal glands, which hide in the fornices, again in an area not particularly sun exposed. And as a result, we have a frequent amount of corneal staining. We've discussed that conjunctival cytology can show several different abnormalities. Here are two. This is a degenerated epithelial cell with pycnotic nuclei and a mitotic figure. Degenerating epithelium with intracytoplasmic inclusions, and these were the compendium of results that we saw from our conjunctival cytology. So epithelial degeneration and inflammation were quite common, along with keratinization. So why do we think this might occur? Well, we kind of suspect that there is UV damage to sun-exposed conjunctiva, which leads to cell damage and then chronic inflammation. This chronic inflammation, however, is not limited to the UV-exposed areas, and the inflammatory cells release all of the nasties that inflammatory cells are known for, and this can lead to damage in the unexposed areas, leading to dry eye, which in turn sets up a kind of vicious cycle. So, although ocular surface tumors do occur, they are less common than the other ocular malformations. So this was just the history of ocular surface cancers, and you see out of the totals that we looked at, it was only a relative handful. The limbus, as you recall, that border between the conjunctiva and the corneal epithelium repopulates the corneal epithelium. It's a stem cell niche, and if it is damaged, specifically by UV light, you can develop encroachment of blood vessels from the conjunctiva onto the cornea called pannus, and nearly half of our patients had that. And advanced cases may result in frank limbal stem cell deficiency. And here's one such patient. This patient grew up literally at the foot of Mount Kilimanjaro, was also not particularly well sun protected, and this is a goblet cell, which is not supposed to be on the corneal epithelium. The corneal stroma was often scarred, and about 10% of those patients, it started to encroach on the visual axis. We also saw, we didn't do this as consistently as we probably ought to have, but in the 11 patients that we measured with specular microscopy, the corneal endothelium also had abnormalities in about 7, so a significant percent, a little less than 70%. As you know, these are post-mitotic cells, and they see UV light, and so they would be at risk for undergoing apoptosis. What we did not see was visually significant cataracts, iris tumors, posterior segment tumors, or age-related macular degeneration in our patients. And then I will turn it over to Ian.
What was the average age of your patients? I'm curious about the AMD. Is that relevant to the population?
So the median age, actually, sorry, I had it up there. It was somewhere in the teens to 20s. So if this was only a slight increase in age-related macular degeneration, we wouldn't necessarily have seen it because it is biased towards younger patients.
Good morning. Thank you, Dr. Kramer and Dr. Brooks for your talks just now. My name is Ian Young, and I'd like to discuss the histopathological and immunohistochemical findings of our patient. Briefly, as mentioned earlier, a conjunctival swab was done 10 years ago, which I'll briefly mention, and then I'll move on to the autopsy findings, specifically what we found at gross examination, then what we found at light microscopic examination, then what we found at immunohistochemical examination, and our colleagues in pathology helped us do fluorescent in situ hybridization, or FISH, and I'll talk about those findings as well. So 10 years ago, Dr. Brooks sent us a conjunctival swab, and I'd like you to look at this photograph down here, and this is a ×40 light microscopic photograph of the left eye conjunctival swab. These are conjunctival epithelial cells, and if you look at these arrows, they're pointing at these little vacuoles here, and that's a sign of a mild epithelial degeneration found in the swab. Moving on to the autopsy last year, this photograph here on the left is a photograph from 10 years ago when the patient first came to the NIH. You'll notice that inframedially, you can see that there seems to be this pannus-like structure growing across the limbus, running from about 4 to about 7 o'clock. And at autopsy last year, unfortunately the conjunctiva has been lost due to artifact, but you can see there's a pacification of the inframedial cornea, which mirrors what was seen 10 years ago at the slit lamp. The left eye is similar. The left eye shows this, originally 10 years ago, we saw this sort of pannus coming in medially, but unfortunately at the autopsy last year, you can see there's an epithelial defect here where the lesion was, but unfortunately it's been lost due to artifact. However, what we do see now is down here at 6 o'clock, there's this new corneal opacification, which was not present 10 years ago when we saw the patient here at the NIH. Moving posteriorly, this is what we found. We found a small pale optic disc consistent with optic atrophy. And looking at the left eye, here on the left side of the image, we saw something similar, another small pale optic disc. But the main finding, as alluded to earlier, was this lesion here. This is in the left eye, and it's it was located supranasally at about 11 o'clock, and you can see it's a white subretinal lesion, which is smooth, and there appears to be some hyperpigmentation of the retinal pigment epithelium just overlying the lesion. Moving to light microscopy, I'd like you first to look at this image here. This is a picture of a normal human cornea, and you can see that this is corneal epithelium, Bowman's layer, the corneal stroma, desquamase membrane, and the endothelium. Now, this is a similar section from our patient, specifically this pupil optic nerve, or PO section, and you can appreciate that comparing the epithelium has been lost over here, and additionally you can see that this patch over here, there's increased staining, suggesting a corneal scar, and the corneal scar appears to have replaced Bowman's layer. At high magnification, you can see this. This is a pannus which is growing across over the limbus, and furthermore you can see these little black dots here are actual inflammatory cells, which on further immunohistochemical staining was found to be CD68 positive, and therefore we think they're most likely macrophages. The left eye showed similar sun-induced damage. What happens is that this is the conjunctiva, and you can see here that it's thickened, and the substantia propria appears to be completely replaced with this dense collagen fibers, suggesting that this is a conjunctival scar. The left cornea is similar to the right cornea. What you can see here is this, the corneal epithelium has been completely lost over here, and once again, you can see this area of increased staining suggests a corneal scar. So both corneas are scarred. At high magnification, this is what we saw. Similar to the other eye, you can see that the corneal epithelium has been lost. Bowman's layer has also been lost over here. And once again, these little black dots over here are inflammatory cells. Moving posteriorly, we found the beginnings of a cataract. So this is anterior and this is posterior, and this is the lens. And if you look here in this blue circle, you can see this fragmentation of the cataractous lens fibers, where the lens fibers appear to be retracting from one another. Furthermore, on this side over here, what's happening is you're developing liquefaction of these peripheral lens fibers, and they're forming Morgagnian globules, which are these little circles over here, suggesting that this is the beginnings of a posterior subcapsular cataract. The left eye is similar. This is a light microscopic photograph of the left lens. This is anterior and this is posterior. Now, normally your lens fiber cells shouldn't actually go past your equator, and your equator's here. And if you look here, down here posteriorly by the posterior capsule, these little two dots here are lens fiber cells that have migrated posteriorly, suggesting the left eye has also got what appears to be the beginnings of a posterior subcapsular cataract. An incidental finding we happened to notice was a retinal tuft. A cystic retinal tuft is a congenital abnormality that's composed primarily of glial tissue. The main clinical finding of something like this is that classically you're supposed to get strong vitreoretinal adhesion from lesions such as this, and you can sometimes get small round holes or horseshoe tears around here. Retinal tufts are present up to 5% of the population, but it is thought the actual risk from retinal detachment is low, and is thought to be probably well below 1% for actually any particular retinal tuft. Regarding the optic nerve, this is what we found. This is the posterior optic nerve, this is anterior and this is posterior. And what you can see here is that this is this increased septi in the optic nerve, which is a sign of optic atrophy. The left eye is similar. The left eye once again shows this increased septi, suggesting bilateral optic atrophy. Moving on to our lesion itself, this is what we found. The lesion was found to be composed of these tightly packed basophilic cells, and they appear to be arranged in whorls over here and also a nest over here. The lesion was vascular. There were a few blood vessels over here, here, and here, and we actually found it to be composed of spindle cells, which I'll speak more about on the next slide. This is, if you look on the left, is a traditional spindle. A spindle is a tool traditionally made from wood, which is used to spin wool or cotton into yarn. And with the eye of faith, if you look here in this patch over here, you can see that these cells appear to mirror the spindle, and they appear to be long, slender, and spindle-shaped. But the important thing is that we can't only find any obvious dark stripes of a spindle A morphology or the prominent nucleoli of a spindle B morphology. Now, the clinical significance of the cell type is that if you have a choroidal melanoma with epithelioid cells, those tumors tend to be more aggressive than those made of a spindle or mixed cell morphology. Other things we found at high magnification, we found some melanosomes over here, and there were also some vacuoles above. And this is just another diagram photograph showing the vacuoles over here. Lastly, and like microscopy, here are the vessels I mentioned earlier, showing that our tumor is fairly vascular. So, onto the immunohistochemistry. Historically, S100 was one of the first immunohistochemical markers for the diagnosis of choroidal melanomas. And the reason why it was the gold standard was because it was very sensitive. So anywhere between 96, it could pick up anywhere between 96 and to 100% of malignant melanomas. However, the main problem with S100 was a lack of specificity. Sometimes it would pick up dendritic cells, and therefore that would lead to false positives. Now, looking at our lesion here, this is the S100 immunohistochemical staining of our tumor, and you can see it does stain with S100. It seems to be fairly black colored. However, the next stain we tried was human melanoma black 45 or HMB45. This was historically the next immunohistochemical marker to be used for in melanomas, and it was discovered by Drs. Gowan and Vogel in 1986, and it's a mouse monoclonal antibody that's been raised against GP100, which is a melanoma-specific marker on pre-melanosomes, and its sensitivity is high, anywhere between 50 to 100%. Now here, when we apply HMB45 to our tumor, you can see that the lesion is much more convincingly stained and much darker than S100, suggesting that our lesion is definitely a malignant melanoma. We tried other things. We tried NSE, or neuron-specific enolase. This is a marker that looks at neuronal and neuroendocrine tissue, And interestingly, if you do aqueous taps on patients with malignant melanomas or retinoblastoma, you can find NSC in these patients. And you can see that our lesion also stains convincingly for neuron-specific enolase, demonstrating possibly a neural component. We tried other neural markers. Another one we tried was CD56. It's also known as neural cell adhesion molecule, and this picks up tumors of the nervous system. However, as you can see that when we applied CD56 to our lesion, it doesn't really stain as positive as the previous two images. The last immunohistochemical marker we tried was GFAP, or glial fibrillary acidic protein, which picks up glial tissue. But as you can see, is that when we applied it to our tumor, it doesn't stain as positive as the previous images. Lastly, we had some colleagues downstairs in pathology who were kind enough to do fluorescence in situ hybridization of fish on our lesion. The reason why we did this was because the modern management of choroidal melanomas, the best practice is to do a chromosomic analysis because it has a direct link with prognosis. So for example, if you have complete or loss of chromosome 3, your 5-year survivability from choroidal melanoma was reduced from 100% down to 50%, and other chromosomal abnormalities that are linked with a poor prognosis include loss of 1p, monosomy 3, loss of 6q, or gain of chromosome 8. The non-monosomy 3 is the most important. So what we did here is that this is just a picture of 2 chromosome 3s, and our colleagues downstairs used a red probe looking at the centromere in chromosome for chromosome 3. And with the eye of faith, if you look sort of over here, you can see there's one red dot and there's another red dot over here, suggesting that these 2 cells here have got 1 chromosome 3 each. If you ignore this bit over here, but if you look at this cell over here, with the eye of faith, you can see possibly about 3 red dots over there, suggesting that this cell over here has got 3 copies of chromosome 3, whilst if you look over here down by this green cell, this has got 2 red dots, suggesting 2 copies. So what we have here is that on this fish image of our melanoma, you have a heterogeneous cell population, and computerized image analysis suggests that roughly 50% of our tumor was composed of cells comprised with monosomy 3. So, to summarize, these are just a summary of the findings that we found at autopsy. We've, as mentioned by Drs. Kramer and Brooks earlier, we found a lot of anterior segment signs. So both eyes had conjunctival scars, both eyes had corneal panuses or pani, and both eyes had corneal scars. We also happen to notice a cataract, so that's the panus and that's the conjunctival scar. Moving posteriorly, we happen to notice a little bit of cystoid retinal degeneration. We noticed a retinal tuft, some drusen, but the main ophthalmic finding was this amelanotic choroidal melanoma. We noticed that it had a spindle cell morphology, and also we noticed that because it stained intensely for neuron-specific enolase, we decided it had a neurotrophic component. Lastly, as mentioned earlier, the patient had bilateral optic atrophy, and we think that this most likely was due to the fetal alcohol syndrome, because Stromland in 1982 described a cohort of children who had fetal alcohol syndrome, and he found that about 13% of patients with fetal alcohol syndrome can have bilateral optic atrophy. So that's what we're thinking there. To summarize, we described a 20-year-old young man with xeroderma pigmentosa, combination group type C. The main ophthalmic finding was a supranasal choroidal melanoma, and which had spindle cell morphology and was positive for the melanoma markers of S100 and human melanoma black 45. It was also positive for the neural marker of neuron-specific enolase, and on fish imaging, roughly about half the cells had monosomy 3. I'd like to thank other colleagues in my lab for their help in preparation of this talk, namely Drs. Chan, Guidez, Abu Assad, and Messrs. Pop and Odoljan. And also I'd like to thank our colleagues from pathology, Drs. Pak and Abdullayev, for the help in the fluorescence in situ hybridization. Now I'd like to move on to Dr. Abu Assad, who will present the electron microscopic findings.
Thank you, Ian.
So there was concern about the fish studies because this fellow had chromosome abnormalities in his bone marrow. And we wonder if if any normal tissue was not melanoma tissue was tested or ought to be tested the same way. So make sure he didn't have widespread melanoma.
At the time, we only tested the tumor tissue, but we have spoken about this recently. We only tested the tumor tissue.
Dr. Kramer, usually this is found inside the tumor, and the normal cell usually do not have. It's sort of like related to the oncogenes sometimes. So like bone marrow, because he had myelodysplasia syndrome, so it's sort of like even what you say it's not a normal bone marrow. The choroidal melanoma, it was published. It's well known that the association with monosomy 3, but the normal cell in the same patient did not have that because it's tumors in the tumor. So sort of like oncogene.
But you have normal tissue from many other places, including many other places in the eye, and it would be a nice control since he does have chromosomal abnormalities in the myelodysplasia, and he has another disease, the choroidal melanoma, that has chromosomal abnormalities. You have the tissue there to check the fish in the rest of the eye to show that the control that it doesn't have.
Sure.
In addition, he has xeroderma pigmentosum, and he was treated with very potent chemotherapeutic agents that themselves can cause chromosomal abnormalities.
Sure.
So he's not a normal individual.
Yeah. I understand that.
And you have it. You have to do something.
Of course, nothing says melanoma like an ICM picture of melanoma. This is what we are going to show you. So we receive the piece of tumor, usually 1 cubic millimeter to do the EM on, and to do the confirmation. This is the toluidine blue of the tissue that we receive. And when you look at the higher magnification, you realize that the cytoplasm is not dense enough. So the necrotic nature of the tumor, and also the nice thing about the plastic embedding for melanosomes, that you can see them actually by the light microscopy. They reflect a brownish color. So I'm usually able to tell if it's melanoma just by looking at the toluidine blue, but not in this one. And the reason, before we go into the reason, let me tell you what we are looking for. What we are looking for usually is melanosomes in a cell that is variable in shape. Usually it's not a nice differentiated shape. And also the melanosomes are premature. Here is what the melanoma melanosomes look like, and here what a normal choroid melanosomes look like. So we want to see if we have something similar to this in the cells of this tumor. This is an image of the tumor, and you can see there are melanosomes, but most of the cytoplasm of the cells is necrotic, and also the nuclei are necrotic. So most of the tumor is necrotic. And so we want to look for a cell that's still intact, and here's one of them. So this is a melanoma cell that is not very viable, but to a certain extent is viable. And here's a close-up showing you the immature melanosomes in the melanoma cell. The mitochondria is almost gone, so all the mitochondria are degenerate here in this image. So looking for more cells, and another one, but as I said, most of the tumor is actually necrotic. So the few viable melanoma cells that we found, I photographed. That's it for the EM. So in conclusion, the EM confirms diagnosis that it is actually melanoma. The ex-patient developed the melanoma despite the fact that he was shielded from the sunlight. Tumor cells were positive for S100, HMB45, and NSE. FISH revealed 50% of the tumor had monosomy 3. And this suggests that XP patients, even if they are covered, should undergo regular examination to see if they develop any melanoma in their cells. Thank you very much.
Any questions? Thank you for the speaker. It was really educational. Thank you. I just wonder, talking about this monosomy 3. I don't know if this patient, because he had monosomy 3, at least in the bone marrow there, maybe that's how he's easier to get melanoma, choroidal melanoma, than the others. Do you check monosomy 3 on all the XP patients?
No. We don't do karyotypes unless there's something.
So say if the patient, you had another patient with bone marrow disease.
Oh, if they have
Yeah.
bone marrow
Yeah.
disease, yeah.
Yeah.
Myelodysplasia. I think
But
we
it's-
have seen like 3 patients now.
So do they have
Myelodysplasia.
monosomy 3 in those 3
This patient
patients?
had many
Not
chromosome abnormalities
Yes.
in addition to monosomy 3.
I understand that, but
Yeah.
for your other 2 patients,
The other myelodysplasia patients that have had chromosomal abnormalities, I don't know if there's been monosomy 3.
so maybe if they have monosomy 3, maybe you should look at if they have melanoma.
Unfortunately, the ones we have passed away, and as
We
Brian
didn't have,
alluded to,
I
usually
thought so.
myelodysplasia occurs at 60 or 70 or 80 years of age, and these were individuals that had it at about 20, in their 20s or earlier, and died very quickly. So it's a little late because we weren't able to get postmortem examinations
No,
on that except for this.
we do have the postmortem exam on the other patient that we did the autopsy here, and you should have his eyes.
If we had the, probably we did not
That's
see
true.
melanoma. I
We
wonder
didn't.
those patients do not have monosomy 3. If you do it, and then you go back to see
We'll have to go back and see exactly what the chromosomal
just
abnormalities were.
which one.
Yeah.
And
Yeah.
If this is the one, they may more think of that.
Yeah, chromosomal susceptibility that manifested in the bone
Yeah,
marrow and in the eye.
Yeah. Brian's new project. Any other questions? Thank you.
Thank you,
very much.
Dr. Chen.